Hello everyone, I'm Serena. I'm one of the fourth year medical students at the University of Nottingham. I'm currently undergoing a selected special module on robotic and gynecology surgery with Mr. Abdul, and this is my presentation that's called Is the Future Robotic? It's an insight as to what the future holds for gynecological surgeons and laparoscopy with continuing advancements in robotic surgery. I'm just going to give a quick run through of what's going to be covered in today's presentation. So I'm going to start off by introducing what robotic surgery actually is, and then give a brief history of robotic surgery and how it has changed over time. And then we're going to look at the current use of robots in gynecology theatres, any advantages and disadvantages of using them in surgery, along with future predictions and advancements in robotic surgery. And then finally, just to cover that all-important question, is to answer whether the future is robotic or not. Firstly, the introduction. And this is covering what do we actually mean by robotic surgery and why is it even used? To introduce the topic, what actually is robotic surgery? So, robotic surgery is also known as robot assisted surgery, and it isn't exactly what the movies or the media might have led you to believe. The idea of robotic surgery comes from simpler models such as endoscope and laparoscopic surgery, which is commonly known as keyhole surgery. Robot assisted surgery is similar to laparoscopic in the sense that surgeons hold and manipulate a scope or instruments through several small incisions that have ports implanted using a trocar. But robot-assisted surgery uses a control unit to move arms attached to the laparoscope and the instruments instead of controlling the laparoscopes directly. Robotic surgeries can range from using robotic arms to assist surgeons using traditional methods, so that's more open surgery such as orthopedic surgeries, and then also to surgeries that are almost entirely done using robots, so that's little to none of the operation done through conventional surgical techniques, for example, when the surgeon is actually touching the wound or the organs with their hands. If you look at the image on the right hand side, it shows a procedure in the abdomen where a complex system of robotic arms is being used, with the surgeon controlling from the outside of the abdomen and a control unit. Robotics are used in many surgical fields, but it is widely used in gynecology and abdominal surgery to treat several conditions affecting a woman's reproductive organs. This includes pelvic pain, endometriosis, the diagnosis and removal of it, gynae cancers such as cervical, ovarian and endometrial, pelvic organ prolapses and uterine fibroids. Now that we know what robotic surgery actually is, let's take a little bit of a look at the brief history of robotic surgery. So that's when did we actually start using robots to assist during surgery, and how have models changed over time? So the word robot was first used in the 1920s, but the concept of robotic surgery was still many years off. 1970 saw NASA experimenting with the idea of telesurgery. Now this is remote surgery is a possibility for astronauts to use whilst in the space station, and this involves performing surgery using 5G data and Wi-Fi. The 1970s also saw the US military researching the concepts of telesurgery for long-distance battlefield surgery. But it wasn't actually until the 1980s that the first robot-assisted surgery actually occurred. In 1985, the first robot-assisted surgery was completed using the Puma 560 model to conduct a brain biopsy. The robot was invented to reduce movement and hand tremors whilst performing surgery. In 1988, the Probot was developed by ICL and used to create several repetitive incisions during a transurethral prostate surgery. By the late 1990s, more and more surgeries such as preparation of the femur for hip replacements and now 3 different systems have been created by engineers which combined laparoscopic technology with surgical robots. This included the Da Vinci model, AESOP and Zeus, which Da Vinci is still used today. The world's first gynae robotic surgery occurred in 1988, which was a fallopian tube reanastomosis. This is essentially reversing a sterilization process. The Da Vinci model and the Zeus models continued to be used for multiple novel surgeries during the early 2000s, until the 2 companies merged and Da Vinci became the favoured robot. The Da Vinci system becomes the most prevalent robotic surgery device in the field and was approved for general laparoscopic surgery in the early 2000s. Moving on, 2010 brings the year of the viral video of the robot peeling skin off a grape, which shows how evolved the robots are to be able to do such precise work. Only 1.8% of surgeries in 2012 were robotic, and by 2020, over 16% of now general and minimally invasive surgeries are actually conducted through robots. Slide is just giving a bit of an overview of how robots in surgery have evolved over time. This left-hand side shows the original Puma 560 model with how it works on this bottom picture right here, which is just a bit of a diagram to explain how simple it actually was. You can kind of see its simplistic model in that it only contains one arm. Now, if you look at the middle, we can see the original Da Vinci and Zeus models. As it was mentioned earlier, the Zeus model was actually discontinued after some time. The right-hand side shows the modern-day Da Vinci models, which are used in surgery today. The models have better arms, better haptics and cameras, etc. The Da Vinci system aims to supplement a surgeon's skill. 55,000 surgeons have been trained on this system alone. The Da Vinci model has been used to perform 10 million procedures, and 6,500 pieces have been sold in 67 countries since it was first introduced in 2000. The main part of the device uses 4 robotic arms fitted with very small laparoscopic clamps that are fitted to various surgical tools, which you can see if you look at this picture here and here. Tools are made specific to the surgery and aid the operation of minimally invasive surgical procedures. Adaptations during the last decade have improved the functionality of the Da Vinci robot, which mimics the actions of the human wrist. This enables surgeons to perform complex movements with precision and ease. There's been very steady growth in the recent years in the field of surgical robots. The market was a little over $1 billion in 2020 and had almost doubled by 2022. Advancements in models include improvement in imaging, degrees of freedom, which refers to the range of axes which the arm can rotate upon, haptics, which is making it more like the true sensation of surgery, and 3D vision, unlike laparoscopic vision, which is 2D and has caused many issues with depth perception over time. Also, miniaturization, which is making robots smaller, is also occurring, so that robots are becoming more compact, and the idea is that they may be able to use multiple robots in theatre in the future. What is our current use of robot-assisted surgery in gynecology? And this is covering what models are currently used in gynecology and what surgeries are performed using robots. Earlier models of robots and laparoscopic surgeries, there used to be quite a few issues seen in gynecology and abdominal operations due to the challenge of restricted access to certain areas of the pelvis and the abdomen. Surgeons would often complain that the robot arms had limited dexterity of rigid instruments, and the same goes for laparoscopic procedures. Models have been adapted over time to improve this, as well as now focusing heavily on reducing scars, improving cosmetic outcome, and as well as improving recovery times for patients. Using smaller robotic laparoscopic tools, such as those used in the Vicarious surgical robot, have helped to reduce incision sizes to as small as 1.5 centimeters. Other uses of robots in gynecology surgery include devices that have been designed to exclusively hold endoscopic cameras, so almost acting as an assistant surgeon would do to a lead surgeon, and they can do this with greater precision, which eliminates the need for extra assistance from fellow surgeons. And if you have ever controlled a laparoscope or an endoscope during an operation, you'll know it is actually quite difficult to orientate yourself and keep your hand steady all the time, especially if the procedure is particularly long. One of the newest models developed by Avatera for abdominal and pelvic surgery can be seen at this bottom image on the right-hand side. This model was created for minimally invasive surgery and consists of 2 units, which is a surgical robot and one part is a control unit. Now, the surgical unit has 4 robotic arms, which is similar to the Da Vinci model, which controls instruments and has an endoscope. The control unit, on the other hand, is a flexible seat for the surgeon, an eyepiece, a manual haptic input devices, and foot switches to control the machine. Unlike the original Da Vinci models, the eyepiece was specifically designed to not interfere with surgeons' mouths or ears so they can communicate effectively with the rest of the theatre staff, which was a common issue seen when using the Da Vinci machine. The image on the right-hand side shows the eyepiece that I'm actually talking about. The image displayed to the surgeon by the system is exactly what matches to the human's natural eye field of vision. In 2022, the Avatera had successfully removed several tumours and been officially approved for use in gynecology surgery, and as we speak, it's actually being installed in medical centres across Europe and the United States. mentioned previously, the Asenis has developed the Senens surgical system. Now, this model has mainly been used in gynecology and colorectal surgery, as well as some limited trials in paediatric surgeries. This model consists of independent robotic arms with a base for each arm and a control station equipped to a monitor screen which enables the surgeon to operate in a relaxed position. And if you go back to the previous slide, you can actually see the relaxed seating position in comparison to the other model. And by other model, I mean the Avatera. The system works similarly by using a foot pedal which activates the robot when pressed and freezes as soon as the foot moves off the pedal. It also uses eye tracking technology for the endoscopic control and has an open design which allows staff to observe the surgeon's actions when standing at the side of the operating table as well as looking through the screen. Again, this is an issue that had been faced with the Da Vinci models where people would often complain as training surgeons they actually couldn't see what was occurring and apart from what was going on in the screen. The two models that I have mentioned are used in hysterectomies, myomectomies, oophorectomies, ovarian cystectomies, resection of endometriosis, sacrocolpoplexies, lymphadenectomies, with an increasing role in gynae-oncology surgeries. And they are expected to increase the use over time and as they are interplated into different hospitals across the world. Now, looking at the images on this slide, this shows a Hong Kong-based company, NISI, which has developed the NSRS, which is a miniature surgical robot for natural orifice surgical procedures. Now, this is the first of its kind and can be inserted through the vagina and the cervix to perform surgery within the uterus. The robot has two arms equipped with surgical tools that are folded within its bodies, and you can actually see the folding arms just here if you look at where my laser pointer is. And it also uses haptic feedback for the surgeon for precise sensing, along with a HD 2D to 3D camera for precise workflow. It is a highly portable system that can also be mounted on the side of a surgical table. And this image on the right hand side here shows when it was trialled first in an abdominal surgery. This robot enables surgeons to access pelvic organs from the inside with minimal scarring. And again, like we mentioned earlier, it actually takes away the issue with the rigidity and decreased dexterity of having rigid objects and instruments because these can fold within themselves. It's quite clear that robots are used quite widely in gynecology and abdominal surgery. But what are the actual advantages and disadvantages of using robot-assisted surgery? Why even bother using robots in the first place when we can use laparoscopes or open conventional techniques? Taking a look at the advantages. Robots now use endo-wrist technology, which means that robots are designed like the human wrist, which enables surgical maneuvers like open surgery, but with smaller incisions and no need to open the patient's abdomen. Furthermore, it's better than laparoscopic surgery, where surgeons have often complained that some areas of the pelvis and abdomen cannot be accessed due to limitations of the rigidity of the laparoscopes and instruments, which we mentioned previously. This means that overall there's better wound healing, it's a less painful recovery for the patient, and the patient is more satisfied with the cosmetic outcome, as no one wants a huge scar across their pelvis or their abdomen. In addition to this, it also enables surgeons with less advanced laparoscopic skills to perform difficult tasks such as intracorporeal suturing and knot tying, as they're able to move the robotic arm similar to the way they would move their wrist in an open procedure, but without the limitations that is found during laparoscopic procedures. Robots have the edge in highly complicated procedures where extensive dissection and proper anatomy re-establishment is required, for example during a hysterectomy. And robots have helped overcome a lot of issues surgeons were facing with laparoscopic surgical procedures. In specific surgeries, such as hysterectomies, studies have shown that there's actually reduced blood loss with robot-assisted procedures when compared to laparoscopic procedures, and there is also one less day spent in hospital. Now, this is not only beneficial for the patient's recovery, but also for the hospital as it frees up beds. Robots are also more precise during adhesiolysis, when surgeons encounter significant adhesions and the manipulation of large uteri during a hysterectomy is difficult. There is a major advantage for endometriosis surgery when the primary goal is to restore the patient's anatomy whilst protecting the patient's fertility. There is also a decrease in incidence of conversion to laparotomy, which is open surgery, and complications when using robots compared to laparoscopy procedures, although the difference isn't exactly huge. Robots cause patients less pain and recovery due to less movement at the abdominal wall, level and less trauma to the wall through the operative ports because their ports are smaller in robots. Less trauma to the abdominal wall means that the actual recovery process is less painful. Robot require fewer assisting surgeons for lead surgeons, which means there could be an improvement in sterility of the operation as well. And finally, using robots removes the issue of hand tremors during longer surgeries. So there are a lot of advantages for using robots during surgery. But of course, like any model, it isn't without its disadvantages. Disadvantages include the lack of haptic feedback for some robots, which makes dexterity sometimes difficult. This means that surgeons say it's not quite the same feeling as when using an open or laparoscopic technique, for example, when grabbing soft tissue. There's also a lack of direct access to the patient, in the case that something went wrong, and often slightly longer procedures are seen with robots. Many literature reviews have revealed that apparently it's an extra 20 minutes for robotic procedures when compared to a standard laparoscopic procedure. Most robots are very large pieces of equipment and take up a lot of room in operating theatres, so it requires big theatres and more money to create theatres that can actually fit them in, as well as buying the machines themselves, which are extremely expensive. There's also the disadvantage that training surgeons and other staff members are not actually able to see what's happening in the surgery from outside or standing at the operating table. There's a potential for mechanical error, which is rare, but it is possible, such as failure of robotic arms and then accidental burn injuries. And it also requires training to learn how to use the robots, which is very expensive and time consuming and isn't exactly accessible to everybody. It's difficult to make the robots accessible and achievable to be used by every surgeon in every country because not everyone has the same standardized healthcare. The most interesting part of the presentation. What are the future predictions and advancements for robotic surgery? So what do we think is going to happen in the field of robotic assisted surgery? Previously, the market size for robotic surgery is rapidly increasing. It's actually expected to be around 19 billion by 2027, when it was only a billion in 2020, and is predicted to grow at a compound annual rate of 17.9% until 2030. Robots are becoming more and more compact, and the idea is that they may be able to use multiple robots in theatre in the future with less people required to be in the operating theatre. From performing surgery over Wi-Fi in a different country, which is telesurgery, and if I use my laser pointer, you can actually see this is what's going on in the picture here. So this surgeon here is in a completely different country than where the surgery is actually taking place, and it's kind of amazing that you can do that from so far away. This was a transatlantic procedure that was done in 2015. Receiving major funding include developments in telesurgery, which is what I just mentioned. So this is the surgeon performing surgery using Wi-Fi and data in different countries with a minimal delay. There are also advancements in voice command robots. For example, the Revo 1 in South Korea is used for laparoscopic procedures, and it also incorporates better degrees of freedom for more dexterity. This model also has foldable arms, which limits rigidity of the instruments and enables better control, and can perform based on surgeon's instructions, which are recorded into the computer. Robots that have arms with ultrasounds are also being developed that can be used during surgery to help identify tumour types and organs behind adhesions. There are improvements in 3D vision, in endoscopes instead of two-dimensional vision, which improves depth perception and enables the surgeon to have an enhanced understanding of spatial view and awareness in the surgical site, which also means the surgeon can confidently perform difficult tasks such as suturing and dissections despite the lack of haptic feedback. If you look where my laser pointer is, this is actually a model of the voice-activated robot that is used in South Korea. There's also the idea of single port surgeries, and this is where multiple instruments are imported through a single port. And this means rather than having to give a patient multiple incisions, you can do it through one smaller incision instead. Of late, some devices have started incorporating haptic feedback to provide greater tactile feeling of soft tissues during surgery to provide better control over instruments. And it's also important not to forget that the laparoscopic tools are actually getting smaller and smaller. So we are aiming to reduce scars and recovery time of patients that are having surgery. To answer the question that we're all kind of interested in, is the future of gynecology surgery robotic? And what I mean by that is, will we still use laparoscopes in the future? And will we eventually reach a point where robots can operate alone? Despite what the media might tell you, we're still a really long way off from having autonomous surgical robots and AI that is used to perform surgery alone. There's a huge misconception in the media that it's actually robots doing the operation when we refer to robotic surgery. As we spent some time talking about today, surgical robots are remote controlled devices where surgeons are still in control of the scalpel. They are used to aid performance and not take over. We are seeing developments in what's called machine learning, which is a type of AI used in changing the way surgery will be done in the future, according to leading experts in the field. Now, machine learning is a little bit complicated if you don't know much about robotics, but in its simplified form, it's a form of AI which is an umbrella term for computer systems that can perform tasks that normally require human intelligence. This is also known as unsupervised learning, and it uses algorithms that have the capacity to learn and respond to data, adjusting and improving their performance in response to the feedback that they receive, which is very clever stuff that is used in computers all around the world. Now, this combined with deep learning which is where engineers construct algorithms that can handle high degrees of complexity, mimicking the neural network of the human brain, which we know is extremely complicated. This is where the idea comes from using this in the future in the surgery. Now, this is actually already used in ophthalmology when taking OCT scans to diagnose diabetic retinopathy, macular degeneration, etc. Models are still in prototype for use in normal general surgery, but you only have to look at what is being done with self-driving cars, for example, Tesla. Driving a car is very complicated, but it's clear that the technology is there, and there is potential to be used in surgery in the future. Now, the challenges of this is perception and manipulation, and these are two of the most important skills for a surgeon, as the job relies heavily on understanding subtle visual cues and fine manipulations of objects. This is extremely difficult for any AI to master, and machine learning deals with a predictable world. Unfortunately, with surgery, every patient is different and very unpredictable, and for an AI to interpret soft tissue and what is going on in a very complex and messy environment is extremely difficult when most humans cannot do that unless they've trained for years as a surgeon. Because of the messy environment and the lack of consistency between patients, it would make it very difficult for any machine to learn difficult patterns and recognise them in the future. There is also the issue of public fear, because many people in the public do not view AI as safe. Now, other ideas focus on machine learning to learn more about the surgery itself and pave the way for greater robotic assistance in operations. So, less about performing and more about how they can aid the surgeon. Bella Giannis is a company that's worked on a model that learns to interpret a surgeon's position and posture during an operation and correlate that with the use of specific instruments. The idea is that this could be used to alert the team to use a certain instrument at a certain time by recognizing the surgeon's patterns and body language, on specific surgeries, of course. The current focus is that robotics should assist a surgeon's skill and not take over it. Robots enable more precise surgery. For example, they use gearing of movements for a surgeon, so that means that moving a tool 1 centimeter results in only a 1 millimeter movement. They also help to reduce tremors, hold instruments in place that would be impossible to hold or manipulate by hand in really difficult, complex scenarios, or when somebody is tired, and are already starting to interplay augmented reality, which provides a surgeon with additional information about the patient in real time, which is being put into practice at the moment. This includes the patient's status, where they're bleeding from, etc., which would be extremely useful to a surgeon during surgery. Laparoscopy and laparoscopic surgery is predicted to be replaced by robotic-assisted surgery in the future. This is because improvements in depth perception, there's better handling, and there's better access to the pelvis as well as ease of the surgeon to be able to perform the operations. This just puts them miles above traditional laparoscopic techniques. The use is a very similar technique to laparoscopy, but it's just more advantages. But we are still a decade or so from this yet, because it requires training more surgeons in robotics and not laparoscopic procedures, which will take time to put into practice, and there's also needs time for robots to become more mainstream, put them into theatres. So none of this is stuff that's kind of in the near future, as in the next 2 years. Most researchers agree that the future of AI lies in enhancing and assisting surgery, not taking over it. The future predicts that collaborations between computer algorithms that are able to spot and synthesize patterns with skilled surgeons who are able to make sense of the messiness of the human body could raise the standard of surgery across the board. So it doesn't look like robots are going to be taking over surgeons' jobs anytime soon. But they are definitely going to change the way that surgery is performed, and they will be incorporated into more and more theatres as we go into the future. Everything from me today. I hope you found it interesting in learning about whether the future is robotic for gynecology surgery, and it's put your mind at ease that we are still going to need surgeons in the future, and there's a very small chance of us being replaced by robots. Obviously, if you haven't set foot in a robotic theatre before, then you probably wouldn't have much of this information. So I hope it's supplemented a bit of knowledge for you. I have left my email on the first slide. So if you have any questions whatsoever, please feel free to drop me an email and I will answer as quickly as I can. But as for now, this is just a list of references used for my presentation. And that's all from me. Thank you very much, guys.